Thank you very much. A very hard act to follow. I'm going to discuss, some of the key collaborations and academic, domains that I think are important in this work. So I'm not going to focus on my institution at this point. I just want to use this as a point of departure for the skill sets that I want to discuss at this point. In my current institution, Teachers College, Columbia University, we have some core areas of expertise in education, right? Teachers and principals, in health, education, and psychology, clinical, counseling, school. So we have, a number of research training programs and, of course, a number of other resources and amazing programs within Columbia University, the T32 here, and you all know about that, at Mailman, a number of resources. So in my field, in psychology, and then I'll focus very soon on psychotherapy training, we are in this intersection between public health, social science, and education. We're trying to develop this master's level program. We have a concentration right now. The next step will be master's level program in global mental health. So it has to be an interdisciplinary approach here. And the three axes, of competency are in assessment, in psychotherapy, and implementation and policy. But I'm going again to use this as a platform for a bigger discussion about some core competencies for training of trainers, in clinical work. So people, when we try to train assessment, we have to train in ethnographic and qualitative assessment, mental health needs, identification of local idioms of distress. We have here in the audience to Rasmussen, who is a wonderful colleague and has done very elegant work in how to interface between understanding local idioms of distress and see how they map on to Western instruments and develop, other local instruments that have sensitivity and can be used for clinical trials, are sensitive to change. And the other important thing, intended and unintended consequences of intervention, research, and practice. So people to go back and understand what happened to these communities after, the initiation of the program. Instrument development validation, for, of course, case identification of the different syndromes after we define what the mental health needs are, and outcome assessment, but also when we develop trainers, right, for global mental health, there has to be skills assessment of trainees. They have to be trained in how to assess whether the trainees learn the competencies. Especially if we follow a task shifting model. The people we train, sometimes I've trained lay people with a high school degree. Or, in India there were counselors, sometimes they have college degree, our supervisors are clinicians, meaning from occupational therapists to, clinical psychologists. We need to find ways, user-friendly ways to assess adherence, competence, and long-term skills retention. So collaborating with educators, and this was actually something that I haven't foreseen going to Teachers College, collaborating with colleagues in education was very helpful to see how they, to learn from the work in assessing, achievement, right, competencies. So in psychotherapy, this group knows very well that gold standards of psychotherapy training are didactics, reading the manual, doing supervision. We try to change knowledge, right, and attitudes, and help the person develop the specific skills. So with didactics, we cannot develop skills. We have to do supervision. We are now trying to train in evidence-based, therapies that are relevant to this work, in CBT, behavior activation, MI. But here is the other area, implementation. So this is new for clinical psychologists, a systems approach, a systems language. Training in community and health delivery routes, M tools and E tools, participatory research and advocacy, and the training of psychotherapy. When we do task shifting, task sharing, many times we use the psychological package as a vehicle to teach general counseling skills. So that's what happens on the ground. So we have to help our, future trainers to be prepared for that. They have to set in motion an iterative process for manual development. Supervisory assess provider competence through role plays. We have been now adding tests to that. The educational literature emerged saying that good old tests actually help a lot with learning, which seemed totally ridiculous to me in the beginning, but the supervisory networks sometimes are less obvious, sometimes hierarchically the person has, there are certain supervisors and then you realize some other people do a better job, so you have to negotiate that. We have to train in supervision strategies to pace expectations according to stage of learning, giving clear feedback. Prepare, provide the support. I have checklists in red. This is a research that I was telling Grand Rounds came from Boeing, that even simple checklists actually save lives and prevent plane crashes, so I'm big on simple checklists. And something that I'm talking to educators at TC, the cascade model we have. We train, the trainer, that cascades into, training. They train future people, they train others. Actually, we know that this is not a good idea. It doesn't work very well. There is tremendous diffusion of that. So we're trying to develop some guidelines after, 2 generations of trainees to involve the original people. And, I have here the challenges. You are all familiar with that. Brain drain, not just to high resource areas, but the big problem, they're higher paying NGOs that hire away within the country. And the others that you all know, we always have to find supervisors to speak the same language as trainers. So here is some research that I would like to see. To link provider competency to patient clinical outcomes. In other words, we have these arbitrary cutoffs from our competency scales, usually, 60 to 80%. I'd like to see some research to show if the effort to get somebody from 50% to 80% really is reflected, for example, in improvement in patient outcomes. I'd like to see some research in testing various training models to see what models for what area, result in better efficiency to leading, say, to provider competency or are not very labor intensive. Research on predictors of long-term skills retention, and optimal models of ongoing supervision, training after, so supervision not just after the training, but monitoring. So my time is up, thank you.